We've done a very good job of managing, at least with our own organizations, our own customers, the volume of GLP-1s to where we've been able to prevent the onslaught and high volume of prescribing of GLP-1s that other health plans might have experienced. However, that doesn't mean there's not value to GLP-1s. So now we have one of our largest employer groups saying, hey, how can we use these in a controlled manner that won't bankrupt us? And really it comes down to what some of the gentlemen were talking about earlier is behavior change and how we change that behavior and look at things differently with maybe using GLP-1 as a tool. So one of the things that they approach this at is not GLP-1s, but curing type 2 diabetes, which a lot of people are not realizing is something that you can do. So I'm going to have Jeff with Hero kind of first of all, just kind of give the elevator speech of what they do and how they affect behavior change and fighting to eliminate type 2 diabetes. Go ahead. No, I'm sorry, before you do that, we probably have everybody introduced first.
My name is Steve Parsons. I'm a healthcare actuary with Parsons Risk Strategies. I was a consultant for 35 years, and in this last stage of my career, I'm a freelance actuary, and my goal is to share my knowledge and help clear the noise in healthcare. So I'm having a lot of fun in this stage of my career.
Yeah, my name is Jeff Bernhard. I'm the president of Hero Health. I've heard a lot of the term BUCA. So I spent many years, 21 years as an executive with Aetna. I ran pretty much all of public and labor nationally, from Ohio to Alaska. And then I was the president of all of Blue Cross Blue Shield Highmark, all their business nationally. Left a few years ago because I just didn't think the solution was there. I got tired of the same old, which much of you are iterating here. And I've done a startup, sold to private equity, and now Hero is my second. So it's good to be on the good side, I guess.
Yeah.
Also, I live in Pittsburgh, Pennsylvania.
Hi, my name is Heather Robbins. Here from South Carolina with AS Medication Solutions as VP of Client Experience. I've got a history, a background in employer health, and so it's my passion to be here working with AS Meds. And in place of Walter, he kind of drew the short straw today with me. I'm in place with him last minute, and when I say short straw, I'm 5'2". So.
Hi everyone, I'm Vijay. I am a 4-time founder, now a venture capitalist out in San Francisco. We are an early stage fund, pretty generalist, but longevity and healthcare is front and center. And we're always looking for innovative ideas that have potential and can make a big impact and help fixing the healthcare problem that we have.
Great, thanks
for having me.
Now, go ahead now, Jeff, and give us the elevator speech here.
So I'll tell you a story first. When I first met Mark for dinner, he actually thought I was a GLP guy from a manufacturer. So he said, get the hell out of here. When I told him I wasn't, the lunch went pretty well. So I'm with you. So Hero Health is a company that we provide the digital therapeutic wrap, the journey for people that are on these medications. We don't just work with GLP-1s. If there's anybody that doctors or nurses in this room, there were weight loss drugs before Ozempic, Zepbound, Wegovy, and so forth. We provide a journey. It's a virtual journey. We are a healthcare provider. We're in all 50 states. Our job is to work within the existing system for employees to get them, if it's Zepbound or Wegovy or Ozempic, on the medication. While they're on the medication, we provide neuroplasticity. We focus on the mind, shift the mind. While they're on the medication, we provide registered dietitians, we provide lab tests, and we provide obesity-trained doctors. A tremendous amount of visits. Our job is to make sure the patient is safe on the medication, that they titrate appropriately, and that we work with the other physicians that are currently taking care. Most importantly, our job is to get the patient off the medication. So they start the medication, and as Mark pointed out, we use the term remission. So our job is to get type 2 diabetics into remission. And I guess just a question I'd ask anybody, if you don't mind, Mark, including the gentleman next to me, is I do this all the time, and I talk to big rooms of doctors, and I ask them one question. Why is it in the American healthcare system an oncologist treats a patient with cancer to get them to remission, but yet an endocrinologist or any other doctor doesn't treat a type 2 diabetic to get to remission? I shouldn't say all, but most. Why is that? The amount of type 2 diabetics, and by the way, I'm not saying all can be put into remission, don't get me wrong, but it's interesting to me that for certain conditions, recent onset of type 2 diabetes, 90% caused by obesity, with these medications it can be done. But you have to ask yourself, I think we all know the answer, but it's unfortunate. So we think differently. Our job is to get them off the medication and make sure they maintain that weight off by shifting the mind.
Yeah, I guess get a little bit off script. Steve, you probably mostly see a lot of diabetic substances come across the claims data that you evaluate. And I would say that if I were to guess, I would say that metformin is probably a pretty highly prescribed medication on that.
It is,
Yeah, yeah. And so then but you know, what's more valuable to you as far as an actuary, having someone that is just on metformin for the rest of their lives, or someone that's no longer has type 2 diabetes?
The latter.
The latter.
Yeah, programs like Jess.
Yeah. So you see risk, then you have these situations where once you comment on just what the impact, though, of uncontrolled GLP-1 use has been within plans.
That's a good question. And Brian Fargus earlier in the other panel mentioned a client that had gone from $30,000 of claims to $300,000, and I'm going to paraphrase him, to over $1 million. And so the three key reasons there are, or common mistakes would be the lack of data, and I'll come back to that, the loose PAs on the prior authorizations, and the last one is sensitivity to employees. Some plan sponsors will want to have it because they have employees would like to have them. So I'll walk through those. The first is the lack of data. So quite honestly, most people didn't see this coming. I have three classifications of high-cost claims. First one is the mega claims. Those are the claims that could be $500,000, $1 million. That's easy to classify. Then I have little big claims. Those are the claims between $50,000 and your stop loss specific attachment point. And typically that could be depending on your size group, $200,000, $250,000. Just the prevalence of those claims under the spec, but above $50,000, it's increased significantly. And I had a large credible data set from the city of Columbus that gave me 10 years of data, and you could just chart the growth of the little big claims. And then my latest one is the tiny but mighty claims, and that is the GLP-1 claims. You take the number of members on a healthcare plan that are obese and the number that would like to take the drugs. So we had a school district, it's public school district, so I could share the name, Sandusky Schools, and this makes it relevant. Their nickname is, or the school nickname is the Blue Streaks. Their drug costs took off like a roller coaster going up a hill. They had gone from $1.6 million spent to $2.4 million, and a majority of that, $500,000 of that was on GLP-1 drugs. My job is not to tell them not to do it. My job is to give them the data. So we built an actual model back in late 2022 to estimate the impact of adding GLP-1 drugs, and I just presented to my local county, Lorraine County, because they were talking about adding it, and I estimated the cost for them at about $1.2 million, The loose PAs, it's interesting, the big PBMs had very loose PAs, and then when they were getting market pressure, they started tightening their PAs, but I would still consider them loose. And then the reason I'm sensitive to employee reaction is, this is a very emotional issue for individuals. So these drugs can help with, help them lose their weight. That's why I focus on providing information to help them, the plan sponsor, know what the cost could be. But it's interesting, Jeff's next to me because we turned off GLP-1 drugs for a large school consortium up in north, just east of Cleveland. But we replaced it with a clinical program to, help them, those who needed it, have a resource. So I'm interested in learning more about what you're doing.
Yeah, thank you. And I just wanted to say a few things because the investor team that went before us and the other panel, having been behind the curtain of the bukas and I guess seeing where the bodies are buried, we, no pun intended certainly, but we have all the data. Whether everybody realizes this, the aggregators of the data, which are the carriers, have all the data on you, okay? Now, that can be a good thing or a bad thing like AI, but there was a famous bank robber many years ago called Willie Sutton, and they asked him why he robbed banks, and the answer was, that's where the money is. For each of you that is self-funded, you know exactly who those 5% are that we've talked about all day, 5%. And you'll see many of them with a common theme. The mouth of the river is obesity. And then down from that, you've got cardiology, neurology, amputation, all the bad things that come with it. So I was glad to hear earlier today, it's 5% drives 50, and then the rest of the 95% of the 50. And you don't have to boil the ocean. And I'm glad the investor team that came up here, the innovation team, the data is so important. We can, all of us, and you probably do this as well, we can take the last 12 months of completed claim data, medical and RX, we can risk stratify it with Milliman tools, and we know exactly who you're going to target. And you don't need a bazooka to kill a squirrel, okay? A 30-year-old with 30 BMI is not the same risk as a 58-year-old with 45 BMI. Treat the patient appropriately. And again, right, Ozempic is not the only weight loss medication or diabetes medication on the market. You don't need to boil the ocean, but I do think you have to start somewhere.
I have no objections in killing squirrels with bazookas.
Not my style, Mark. I'm just saying.
Way too many of them I live in the kingdom of the squirrels. Well, now ASMeds obviously distributes a lot of the substances to a lot of our communities through the clinics and stuff like that, and even being a channel for GLP-1s or weight loss drugs that we are going to acquire. But I'm just curious, what have you seen as far as the volume increase over time of GLP-1s compared to what? Has that replaced then the other diabetic or weight loss drugs, or what's been the trend that you've seen, both cost and kind of volume?
Yeah, no question that there's been an increase, just like Brian had said earlier, and I think he touched on it as well, is, you've got a group, for example, that started out with about $35,000 worth of claims, and within a few short years was a few $100,000 worth of claims in GLP-1s. So yes, I think we're seeing that across the board, and as we were talking about earlier, you also have individuals who are more in control of their health, and they're demanding these GLP-1s.
Yeah, it's interesting in pricing these, and I may talk a little bit about a program we're proposing for one of our employer groups later on, but in an insured situation where the GLP-1 is covered, we're talking about $12,000 to $15,000 a year drug. In an uninsured situation, we're talking about a $5,000 to $7,000 a year drug. So finding unique ways to acquire and use those substances is kind of one of the pathways they're going to say, how do we walk this delicate bridge of member happiness and better outcomes in order to minimize type 2 diabetes. So Vijay, I'm just curious your take on all this, and what kind of strategy would you recommend or would you like to see when these kind of things come into place?
Yeah, it's a good question. If I may ask, how many founders are out here in the audience today? A few, okay. And how many, I know there's a few investors, but how many people are thinking about starting a company in preventative care or lifestyle medicine? Okay, not many. Yeah, yeah, it's a tough space. So as a venture capitalist, we're always looking for companies that have a good, solid go-to-market strategy. And I was a founder before. Now I'm a VC, and I'm realizing that we don't really understand go-to-market strategy that well. It's often confused to a marketing strategy or a product launch. And maybe for corporations that makes sense because they have unlimited resources, but startups don't. And so what we're looking in a go-to-market strategy is really a founder to articulate how can they really validate their business to get to product market fit. Not once you've got to product market fit, how are you going to sell the product? And many companies fail to explain us that way. So we're really looking for the roadmap. And so to your question, it's really important to have a really solid go-to-market strategy. Now, in healthcare, we generally see two types of companies. One company is a much better treatment, an innovation on the treatment side or on a procedure side, on a diagnostic side. And for that, we're looking for validating the science and validating the technology. But then there's companies such as Hero where it's more of a cost savings play, where you're looking at the system as a whole, the healthcare system, and you're kind of modifying the bells and whistles in multiple different areas, and you're really, the value proposition is an economic one. And so for those companies, what we're really looking for is, we already agree that preventative care can save a lot of cost. It's proven diabetes type 2 can be reversed. That's already proven. So we're not questioning that. What we're really looking for is, can they really convince payer-provider combos, or in this case, self-insured employers, to really adopt it and to really take it on. And then eventually, if they even have better data or KPIs that can prove out their value proposition, then that's just cherry on top.
Good. Well, Jeff, let's go back to you. Let's talk about the way you're normally used to doing business, rather than the way that we're going to be asking you to do business. In your go-to-market strategy, in your situations, and when you come to an employer group, let's assume you've got an employer group and they're too late. The GLP-1 utilization is up there. What are you going to do about that for them?
Well, I think the first thing you do is, and I think, Vijay, this goes to your point, and I think the investor group said this as well, you have to identify really what the problem is to start with, and then prove what you're trying to solve. As was mentioned here earlier, we've seen in 2021, about 15% of type 2 diabetics took GLP-1s. According to the ADA, NIH, by 2028, it will be 80%. Okay, so it's a straight climb upward. And so what we want to do, to answer your question, is come into a population. We're not interested in being a marketing point solution. Everybody's done with that. Okay, we want to be scientific. We want to be mathematical. We want to prove it out to you. There's not a single person in this room who's dealt with benefits that does not know the impact of class 3 obesity and type 2 diabetes on claims. I mean, it's almost common knowledge right now if you look at a claim report. So we want to, number one, as the prior group said, stratify the data. We want to know exactly what the risk scores, retrospective and prospective risk scores on everybody. And then we also want to know the claim spend for the past 12 years. And if we can get 3 years, see if we can identify patterns. What we then want to do is put them on a different programs for different categories. Again, you don't, all of these patients, whether you use a GLP-1 or you use bupropion or naltrexone, right? Which is, I guess, commonly known as, what's the name of the drug in the market? I'm blanking.
Metformin?
No, the
No,
oral, Contrave, excuse me.
Contrave, yeah.
Contrave. But stratify it. But everybody needs, and VJ, back to your point, they need access to care easily. And that's the other thing that we provide, 20 visits a year with dietitians, mind shift folks, neuroplasticity, and obesity trained doctors. And the beautiful thing is they all talk to each other on behalf of the patient. And we also talk to their other doctors. So we coordinate it. So the answer is we stratify it, we measure it, and we look at the risk scores 6 months, 12 months, 18 months, 24 months. And we should see it start to decline over time. We should start the weight come off. We should start to see the ability for them to titrate off with labs. And even if people do not hit remission, Mark, they're fundamentally healthier than they were from a metabolic state, cardiometabolic state than before. But what we want to do is we want to measure what we did. I want to be able to provide the data on the labs. I want to provide the data on the claims. And I want to provide the data on a risk score. Now, sometimes risk scores, Mark, don't always line up with claims. So what do I mean by that? Well, if you know any orthopedic surgeons, they're not going to typically operate and do a knee on someone that's 80 pounds overweight. So they lose the weight effectively, and then they get the knee surgery, so there's a claim. So you have to get into the details of the data, and I hope each of you that are self-funded have a privacy officer. The privacy officer is obviously sworn to privacy, but that's the level of detail that we have to get into. And then lastly, I'll say, we have to put AI against this. We will use AI in the background to be able to predict future events that may happen for anybody. It was mentioned earlier, in 2 or 3 years, the IQ for AI is going to be 500. Okay, it's 3 times higher than any individual that's ever lived on the planet, or almost 3 times higher. So I think it can be used to predict events before they occur and to also improve patient experience. So, but I'm so glad I heard today it's about the data. And any point solution out there has to prove it to you, has to prove it. Start with the high claimants first and then work your way down. You don't need to boil the ocean, folks. Just start somewhere.
Any comments panelists want to add to that, what you said?
Well, so I completely agree with it. Healthcare has definitely become a data play. There's data at your fingertips at all times. And so back to the second category of companies I was talking about, companies that can save cost. From an investor perspective, what we're also looking at is we probably know that payer providers or TPAs or SIEs, they all have access to data, and they're probably looking at their costs and what are the biggest, highest priority cost line items or what they can do to change it. So what we're looking for is that when companies come to us, startups come to us and claim that they can save costs, which we know they will, we're also looking for TPA, SIE, or payer provider buy-in, because that gives us an indicator that it's in the top 5 or top 10, whatever. It's something of concern to them. So if there's startups such as you that can have that kind of partnership and can demonstrate that early on, then that's a huge soft indicator for us.
Yeah, I think, Jeff, we talk about, and Steve mentioned earlier, he sees the metformin claims last forever for the rest of the health plan's life. But if the person's already on a GLP-1 and you're hired, and your goal is to take us down that pathway, how long will you take them through a program to achieve their goals? Because they're already on the GLP-1. What else are you doing then to solve that problem?
That's a good question. So before we start our journey, let's call it, for each individual. By the way, it's a patient journey. Every patient is different. Everybody's going to respond differently. We get prescribing patterns. So if you have 200 diabetics, send us your prescribing patterns. What the prescribing patterns look like for 200 people that see 50 different doctors is if you threw a bowl of spaghetti against the wall. It's like a splattergram. There's no rhyme and reason behind the titration, and that's why it doesn't work. And I'm not blaming the doctors. Let me be clear. They are extremely busy. They're seeing people for the flu, COVID, Ozempic, and they see 50 people a day. When all you do, like an orthopedic surgeon that does just hips, just knees, and you treat people day in, day out, 45-minute appointments, and you treat them for that, you get really good. So the answer to your question, Mark, is it's all about the titration. The titration is the increasing of the medication to the patient's ability to tolerate it. The reason we want to continue to increase it is that these medications, one of the advantages, it does reduce the food noise, okay? But eventually your body's going to fight back, and then you'll get hungry again. So when that occurs, we bump you up again. But they only go to a certain level, okay? So Mounjaro, 15 milligrams, Wegovy, 2.4, Ozempic, 2. Our goal, Mark, is to get you, if just obesity, is to get you off that medication in month 12 or 13 if you don't have diabetes, and start using other generic medications to titrate you off. For diabetics, we like to get at least 60% into remission, 60% after 24 months. Those that don't hit that, we look at the hemoglobin A1C. And by the way, we own our own professional corporation, so we're not doing the corporate practice of medicine. The doctors decide what to do there. But again, there's going to be a certain subset that is not going to be able to get off the medication for a variety of reasons, but they will be fundamentally healthier. But 24 months is it for type 2 diabetics. It's usually, for the diabetics, you get 20% remission after 12 months, 40% after 18 months, and about 60% after 24 months.
Okay, so it has an end. And
There is. There's a beginning and there's an end. Now, for some patients, again, they're going to have to continue on that medication. But let's keep in mind, if you're going down by 60%, they're going to be replaced by other people. So the train's going to keep coming down the tracks. Unfortunately, everybody knows we have an obesity issue in this worldwide, not just in this country.
And during that journey, you have them give the patient access to certain professionals to assist that, such as.
Yeah, so you have 20 visits a year. You've got 8 or 9 obesity-trained doctor visits, 3 or 4 dietitian visits, 8 or 9 neuroplasticity, where while that food noise is calm, is learning new relationships with food and trying to create new neural pathways around how you're dealing with food as you move forward. Because at the end of the day, for all of us, myself included, where the mind goes, the body goes, and unfortunately the mind does not get enough attention in the system. In fact, we work with a few large hospital systems, and we do partner with their their surgical bariatric practice, and one of them came into us and he said, "Let me ask you a question. Do you focus on this?" And we said, absolutely. We told him about our program. He said, thank goodness we would have thrown you out of here. Because just like surgical bariatrics, recidivism occurs. People go back to their normal state again. So it's not to say they can't fall off the wagon, Mark, but we got to keep working with people. This is not a one and done situation. It's ongoing.
Okay. All right. Now, so normally you're going into a group that has overdosed on GLP-1 situations and is bankrupting their plan and stuff. But now let's talk about if the goal is to diminish the number of type 2 diabetics on a plan, and now I have plans, and particularly within our space, they don't have a GLP-1 problem, but they have a metformin problem. So so how are we going to address that? So we've been in discussions with one of our employer groups about saying, well, how do we stair-step our way into going after the type 2 diabetes situation in a manner that we can use GLP-1s as a tool and show the ROI that in the end we've solved the metformin problem, because to a great extent we've solved the type 2 diabetes problem in the situation. And I call metformin a problem because any tiny drug company can give you something you have to take the rest of your life that isn't a cure. That's a good drug deal, even though it's a very inexpensive drug. So we've talked about stair-stepping this, and we took a population and evaluated that population, and you had some suggestions about how to stair-step this over time, because there is an expense to this, and how to adjust that.
Yeah, so it's interesting. I know the group you're talking about, and I've studied the data. We got really good data. What's interesting is that in this population, the people that have class 3 obesity have higher costs than the diabetics. So think about that. By the way, they're the same people. It's just that one's got a diagnosis of diabetes, one doesn't. So again, it goes back to the fact that obesity is driving it. So, I think what we have to do to answer your question is exactly what I said before. Let's look at the risk scores. We got the risk. Let's look at the claims, and not have one size fits all. One program may run X amount because there's more virtual doctor visits, doctor time, and the other one's a little bit less and a little bit more AI. And I think the one size fits all is a big problem for our system, and your ability to adapt that virtually can do that. So we can start with a certain population, the client's choice, either those are the highest in risk costs, risk factors, and cost. We can stratify it any way possible. I think the important thing as a self-funded customer is that you watch your discriminatory status and make sure that you're picking a level playing field if you want to do it by BMI or cost, and then certainly have an external party do it. People that don't know the patients that are involved there. But to answer your question, again, stratify the risk and create 2 different plans. Now, this particular client also has a health clinic, right? So we love working with health clinics. It's the best because now you get your combination of virtual care and in-person care. So we just wrap around the clinic. We'll wrap around a hospital, a doctor office. So health clinics are actually the on-site clinics are the perfect clients for us, and most of our school systems actually have them. So that's the answer.
Okay. So when we talk about then going through these programs, and I guess as a matter of disclosure, these are the new companies that are doing this today. They've not been around forever because GLP-1s not been around forever, and the problem is brand new. And Hero is actually ahead of the curve on the development of these kind of services in order to address the GLP-1, or really the type 2 diabetes dilemma. But he also is interesting. He said that obesity was costing more than the diabetes was, because the diabetes is well managed, but the obesity is not. So since I would recommend this to my customers, I thought, well, let's just figure out how this really works. So I entered the program myself, and they said, yes, I qualify because their doctor said I was fat. So I slapped him and entered the program. So I'm just now, though, to my 4th week of a meaningful dose, and also not a whole lot of change right now, about maybe 7 pounds in 1 month at a lower dose, and I go up again, and all. But it is interesting to say from personal experience that your appetite does begin to change, and all. So I am suddenly just consuming less at one point in time. I get hungry just as many times a day as I ever got hungry, but the volume that I eat is a lot less because all of a sudden my body's telling me it's full and stuff. So this is one of the few, I've done this once before, been a guinea pig for stuff I recommend to my customers. I won't talk about that one, but, don't get me off track. No. So I'm going to be reporting to my customers themselves what kind of problems you have, what are the side effects, stuff like that. Right now, for me, not many side effects. I mean, of course, I haven't gotten very far down the journey as of yet, But one of the ways we're talking about stratifying this, and we're working with this with even with AS Meds and our third-party administrator and the clinic organization, as Vijay was saying earlier, all coordinating these services together and these aspects together for the collection of data. And to get that data together so that when we're done doing this, we can really show a hard ROI from all those sources of what really happened, from a cost of drug standpoint, to a cost of care standpoint, to an outcomes standpoint of how the member really was able to change or alter their behavior. And in what will be coming to you as our group, and it's one of our groups, they haven't officially adopted it yet. That's the only reason I'm not officially saying their name. But we've done all the evaluation, and we've done all the homework, and it looks like it's something that Cheryl Morgan is going to say, yeah, we're going to recommend you take action in this area. And so if this goes well in this group, in this situation, most of our groups will do a stair-step situation. We're going to come in and say some small population you have right now, maybe 2 or 3% of your group, really are still approved, got a GLP-1 approved, and they're on GLP-1. We'll hit that population first. The smallest you have that's already on there, see that the behavioral training come into effect, and then begin to wean them off the drug as he I can't say the word right now. Titration. Over time, and moving them off of that drug. Then the next population would be those that might be type 2 diabetics. Now, what's interesting to me is in a population of 36,000 members, there was 490 type 2 diabetics. So if you put that on a risk factor and looked at that going forward into the future, you're talking about you could predict some high claimants later in life because of that. All right? So if we're able to cut that number by half, or by 2/3, or by 80%, then we've really impacted the long-term status of that organization in underwriting future risk. And then maybe from there they say that because this group's actually come to us and said, we want to address this problem. Our people are begging us for the drug. So how do we do it? After that, we're going to talk about possibly going to those that are just morbidly obese and stair step it. So because what's going to happen is when you address a problem, it costs you something. Innovation ends up costing something. So your cost for a brief period of time would go up because you're now paying for a service to address an ongoing problem. But if successful, then it drops off, it sunsets, boom. And so then by the time you address your whole population, you might be spending 5% more on your health plan. This group might equal $1 million over the whole time that they might spend, but would reduce their risk and their healthcare costs substantially because they've removed the number of type 2 diabetics on the plan, so the long-term outcome is meaningful. That's the kind of data I want to be able to give to the investors of the world and stuff like that to help support those kind of operations. And particularly in this particular instance, we have a lot of good data and a lot of good examples. And it's going to take 3 to 5 years for us to really get the tail end of what this looks like. But we'll know how good our results are going to be probably in about 18 months, I would say, probably the front end. All right, we've got just a few minutes left, but I guess was anything anybody wants to add to the discussion here?
I was just going to say that to your last point here that we're always looking at data, but data is a snapshot of the present and maybe the past. But what we investors also know is the future of healthcare. And so for the first time, American population in the next decade is going to be over 40 years old. And that's because the last of the baby boomers are now passing 65. Our growth rate hasn't been the same. The health span to lifespan gap is only increasing. The caregiver to caretaker ratio is going to see a step function jump in the next 10 years. And the geopolitical situation, the political situation, maybe a recession, all of those are not a good environment. So the next 10 years for healthcare are going to be pretty disruptive. And so I can't speak for all investors, but our take at our fund is we're looking for companies that are already seeing the future the way we are, right? Even though we let the companies dictate what the future is. We always want the startup to be the whisperer of the future, not us putting our ideas. But we still look at hundreds of startups a week, and so we fairly get an idea of where this world is going. And so startups such as yours, Hero Health, they're seeing where healthcare is going. Costs are increasing. People are getting much worse health. The health span and lifespan gap is increasing. And so where do we go from here? So I guess I was going to say that the next 10 years are going to be very disruptive. And in my opinion, for those payers, providers who don't really adopt to this new world of innovation, like you said, there's a cost to innovation, but to not act, there might be a much bigger cost coming up. So the time to adopt is now. Sorry, that sounded negative, but and on a positive note, that if there's anyone who can do it, it's American ingenuity and our healthcare system, which is one of the top in the world when it comes to innovation. So I'm excited about the future.
Well, let me try to pep everybody up before we get drinks.
Yeah.
And then get unhealthy. No, I'm just kidding. But the exciting thing here is, we're in a global economy, and it's going to get bad before it gets better. So what I mean by that is all the darn commercials you see on Ozempic and Wegovy, you're going to see a lot more within 2 years because you got competitors are coming out. But usually with competition comes improved pricing. We've already seen significant pricing, right, on direct Wegovy and Zepbound. So, fast forward 10 years. Think about when this thing hits generic. You're going to have a world that is not going to be as large as it was before. So, clearly cardiovascular issues, transplant issues, it's going to get better. What weight does to this global economy is not just diabetes, but everything else. It's going to get better, but you couple that with AI and technology and data, it's not uncommon, right, for people to be able to live to 110, 120 now, in addition to all the other stuff. I don't know if I want to be around for 120, but it's exciting because the future generation will really benefit from this. And what the advances in medicine are incredible, but we're just paying the price right now.
I mean, we don't know if people are going to live to 100, 120, but you ask young kids and ask them, like, how long do you think you're going to live? And they hit the 100 mark. So the younger generations are already making decisions that they're going to live to 100 years. And the way we're improving the lifespan seems pretty realistic.
Should be interesting. Any questions from the audience? Yes.
I just had a quick question. I want to kind of circle back. I didn't have my glasses. I would have never found the button. So two things. One, you guys mentioned that there is, and I think Jeff was talking about this, there is some sort of light at the end of the GLP tunnel for a patient, but I'm wondering, especially since the majority of my life is dealing with unions and negotiated contracts, what does that look like? Is the provider supposed to stop giving you the magic sauce? Or is it going to be plan design driven? Who's going to make that person stop taking the GLP-1 when they've reached some arbitrary set by somebody else goal? I can't imagine how that's going to work.
Yeah, well, the way we do it now is it's usually written into the plan document that we are a digital therapeutic wrap. So that means that if you want the GLP-1 medication, you're required to stay adherent and compliant with the doctor visits, the dietitian visits, the labs, everything. Should you become uncompliant, it will either cost you a lot more money, $150, $200 more a month, or you'll be removed from the program. So I would think of it the same way that you see digital therapeutic wraps for Enbrel and other expensive drugs. So I think you're going to see digital wraps around a lot of these expensive drugs because of compliance issues, adherence issues, and at the end of the day, people just want the drug, right? They want the shot, but we know what the outcome is. When you stop taking it, the weight goes back on without any other work.
And if I could add,
plan documents to answer your question.
Yeah, and add with that, we're not going to have our plan sponsors that are planning this program change their plain language. It's a very, very stringent pre-authorization policy that gets them approved to begin with. That's why such a small number are on it. We're going to, as much as we can, keep that policy or exclude them. And we're going to cover them through another what's called a health reimbursement account outside of the plan that can reimburse the cost of the drug for the member as long as they're compliant with the program and want to run the program through the clinic. through that operation. The reason it's important to do it outside of the plan and essentially not cover it is because that price I mentioned earlier, the $15,000 opposed to the $5,000, that's how we get the $5,000 price, is because they're technically uninsured for the substance. So that way we're covering it that way.
So I think another way of maybe saying it, Mark, is that they're setting up a limited HRA,
Yep.
and they're setting a defined contribution approach each month. You get the money every time. Depending on how nice the plan sponsor wants to be, we'll pay it all for you if you're compliant. If not, $200 comes out of your paycheck. But with all the new rules, with the new legislation, you're going to see more and more defined contribution, similar to ICRA plans.
Mm-hmm. All right. Anyone else?
Can't see it, lost in the light.
Yeah,
I mean,
one last question before drinks. Sorry, guys. Anyway, my question to the panel here. Thank you guys for a great discussion, by the way. Just thinking about unintended side effects of this, proliferation of GLP-1s. As an example, I guess I've been reading that the U.S. consumption of sugar and corn has gone down precipitously, and that's why Frito-Lay's stock isn't doing great. So. Just curious about any coming demographic changes or, numbers, whatever you want. This is a free-for-all question.
Well, I think the first thing we have to remember, particularly about a HERO program, is that its objective is going after the GLP-1 utilization and reducing it. It's really not a matter about prescribing it to begin with, and it's also not the only thing they prescribe. I think that the side effect situation of GLP-1s, it's like any drug that's going to be overused by society. It's going to be overused, and what we'll find is that the drug was tested, its efficacy and its side effects were tested for 70% of our population. And 30% of our population, we have no freaking idea how they're going to handle it by the way they've tested these drugs. So that I think 10 years from now, you're going to see the proper utilization of GLP-1s, and you want to see the commercials on TV that say, if your doctor prescribed for you a GLP-1 and you have these side effects, and it's not a matter of trying to use the drug correctly. It's a matter that the drug will be used incorrectly. When we talk about the Hollywood version of taking the drug, the bride just wants it because she needs to lose that 10 pounds for her wedding. That's exactly the wrong way to be prescribing the medication, utilizing it. So I think it's going to have to be addressed the same way the other drugs that have been overutilized in the past, is that a certain population is going to be affected poorly because they weren't under proper medical guidance in their utilization.
Yeah, the other thing to think about to answer your question, and this is why it's really important to have a doctor that's board certified in obesity or endocrinology, I guess. The older you get, it gets very dangerous to lose muscle mass. Very, very dangerous. So if you lose muscle mass, people joke Ozempic face, Ozempic butt, but it's really not funny. It's a very dangerous situation for people, so you have to be monitored with your protein intake, your elastic training, and your exercise and so forth. And the answer, a little bit to your question, people that have been on our program that successfully have gotten off the drug, and because they've had new neural pathways, they don't associate chips and pizza and bread the same way. They have almost a disdain for it now because they have weaned off of the high sugar content and the carbs. So, it doesn't mean they don't fall off the wagon again, but I think you've already seen it impacting the food industry. The problem is it's not widespread. Only 1.5 to 2% of our population takes these medications now.
It just seems like we maybe aren't looking at all of the unintended benefits, and I see this in clinic, and I also see it in my work with unions. The upside to the GLP-1s, I believe, is that every 4 weeks you have to see a doctor. And so we are building a new trust with the doctor or the provider, and we're also, I know that oftentimes we say claims are going up with the GLP-1s, and Jeff, I think you touched on this, it's important to understand what those claims are. If you're now looking at your hypertension issues, and you're looking at your musculoskeletal issues, those are unintended claims, but they are helping in the long run, and we're building that new relationship. So great benefit for the person, great benefit for prevention, but looked at it as an unintended consequence because now claims are going up.
Yeah, look, it's a really good point. I mean, I think claims can go both ways, right? But most of the people, as we watch them and monitor them, your point, the blood pressure goes down, no longer need knee replacement, hip replacement, cholesterol goes down, triglycerides go down, ultimately the heart health improves. But we live in a society, and I get it, all of you that are working with CFOs, we budget from year to year, and things don't carry over to the next year. But if you have a population that's going to be with you a while, 3 to 5 to 10 years, you're going to see the change. I'm not sure it's going to happen in year one for people new taking the drug, because even if the drug is $6,000, Mark, it's still a drug, it's still a cost you're not paying. But I would argue, to your point, I think you're paying it somewhere else. You're paying it in the system, whether it's MRIs or angiograms or whatever the case may be. And Mark sent me a case one day, and I asked him. I said, I'd like to know the cost of all the diabetics in this group. And so I looked at it and it said $3,000 a year. And I said, that's impossible. This must be the healthiest group ever, because it's a lot more than that. That's just the diagnostic codes for diabetes. When you added up all the other downstream, it was 17,000. So it's an interesting thing. And the last thing I'd say, I know we've got to go to drinks, Mark, but you don't need to boil the ocean. The worst thing you can do as a self-funded is do nothing, because unfortunately, this problem's not going to be able to be swept under the rug.
Yep.
It's not, unfortunately.
In closing,
somewhere.
Jeff told me something before when we first met. He said, everybody thinks it's really the drug, and it's a drug problem. He said, it's not. It's a food problem. And just from our panel beforehand, it's how we address food that solves the problem, not really the drug. The cost of this drug and it being so high in the world of drugs is a temporary thing. 6 years from now, 7 years from now, the drug cost of these substances will not be proportionally what they are today. That will change. It's temporary. And the benefit of the drug will be seen more heavily, I think, in the future, because it will be more affordable. However, really, the drug in its short-term use, if it was the drug, you'd be using it the rest of your life. It's not. It's the tool to address the food problem. And that's really what this is all about, just like the prior panel said. So thank you, guys. Appreciate it. Thank you.